Measuring the effectiveness of cancer treatments is a very important challenge and something that hasn't been solved for very effectively to date. So a patient endures chemotherapy, radiation therapy, and unfortunately we really don't have a good measurement process so we can improve the treatments or change the treatments to be more effective. Jeremy, at Rna Diagnostics, you've created a process and technology to do that. How does your technology work?
Our technology is the Rna Disruption Assay, or RDA test. And basically what we do is we measure the ribosomal RNA from cells from a biopsy of the tumor as treatment is going on. And if the tumor cells are responding well to treatment, i.e. being killed by the treatment, then their ribosomal RNA gets cleaved. And we measure that. And the reason that happens is because they're trying to stop protein synthesis and conserve resources. And what we've shown in multiple patient tests is that when this cleavage occurs, that it is highly correlated with the clinical outcome for the patient in terms of an improvement in response and also improvement in survival.
The workflow today is a diagnosis happens of a particular form of cancer and then treatment procedures begin. How far along is someone before your test makes sense to assess?
So in a typical 6-month course of treatment, we can run our test after only 2 to 3 weeks of after treatment initiation. And so basically very early on in treatment, we can indicate to the doctor and the patient either this treatment is working or it's not working and you should switch to the next best alternative.
The effectiveness of treatments is on a spectrum of outcomes here, from very effective, I guess, to not effective at all. You're able to categorize these tests, and how does that make it more effective for the practitioner to evolve treatment?
Basically, we report out the results of our test in one of 3 zones. So if the patient's result is in zone 3, that means that the drugs are working and the patient and the doctor can continue with confidence. If the patient's result is in zone 1, those drugs aren't effective for that patient and they should consider the next alternative. And if the result's in zone 2, that indicates a partial response. And in that particular case, you'd probably keep going with those drugs, but you might run the test again a few weeks later to see which direction that result is going.
So this sounds like it's going to create a lot of cost savings for the system, but also really help patients have a better experience in what is obviously a very difficult situation for them personally. Have you been able to measure the cost savings you're going to bring to the system?
Yeah, we have some modeling of the healthcare economics of our test, and basically because the costs involve both extremely expensive drugs and also a lot of toxic side effects, those cost savings are substantial. Based on the modeling that we've done to date, approximately $30,000 per patient are what we have seen with the benefit of this test.
You've got a number of clinical trials that you've completed already. You've got a big new one called Brevity underway. What do you hope to achieve with Brevity?
So Brevity is a 700-patient clinical trial in stage 2-3 breast cancer. And basically what we want to prove is that with our test, when we indicate that a particular drug treatment is not working, that the doctor can really rely on that information that that particular drug's not working. And the reason is that that's the clinically actionable result, because the doctor then wants to switch to whatever the next best alternative is or go straight to surgery or what have you. And so they need to be able to rely on that result. And Brevity, the clinical trial, will prove the performance of the test, and particularly our primary endpoint is around that zone 1 non-response result.
At proving the effectiveness of the test, do you have an idea yet which amount of the tests are not going to give you the proper indications or the outliers?
Not from Brevity, because we're too early in the process in that clinical trial, but we have done other clinical studies prior to Brevity, smaller studies, and they've indicated 95% or better what's called negative predictive value from the test, which means a negative answer is 95% or more reliable. And that's well within the range of what doctors are looking for.